Hey guys, it's me Samya, and today we're going to talk about anemia's summary and its classification. And I'm going to help you guys on how to frame this question for your exam. And let's start. So, as we know, always start with the definition. What is anemia? Anemia is defined as a deficiency in hemoglobin levels, and you should know the values that are there in males and that are there in females, and which is 12.5 to 16 gram per deciliter in females, and in males it's 13.5 to 17.5 gram per deciliter, and if it's anything lower than that, that indicates that it could be anemia. Then the next thing that we're going to talk about is the symptoms of anemia. Now, symptoms of anemia, since we have reduced hemoglobin, that of course means that we're going to have pallor, which is when we like see under the patient's eyelids, it's going to be pale. When we look at the tongue, it's going to be pale. The skin, it's also visible on the skin. There's also going to be fatigue, tiredness, compensation mechanisms such as tachycardia, dyspnea, also hepatosplenomegaly, because we're going to have reduced, if we're going to have reduced RBCs, so the liver and spleen are going to be like, okay, we need to produce more RBCs, and they will undergo enlargement. So that's going to lead to hepatosplenomegaly. Some diagnostics include blood count to check the overall levels, hematocrit, hemoglobin, red blood cell indices such as mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. This can help us check whether the patient has anemia or not. After talking about the diagnostics, complications. So anemia can eventually lead to hypoxia, low oxygen levels in the tissues, and can lead to injury, and that can lead to atrophy, necrosis, and fatty change. Classifications. This is very important. So we have two classifications in anemia, which is the morphological classification, etiological classification, which I have written by cause over here, but these two are the main important ones that you guys have to remember. So before I move on to morphological classification, there's one term that I want you guys to be familiar with, which is MCV, mean corpuscular volume, and it indicates the average volume of one RBC. In simple words, just think of it as the size of the RBC. So it's basically the space it's gonna occupy, but then let's just say it like size, the size of the RBC. So this is the flowchart for morphological classification that I have made, and I hope you guys have to draw this in your exam. If you guys draw this in your exam, I'm pretty sure the examiner is gonna be happy. So the morphological classification consists of microcytic anemia, normocytic anemia, macrocytic anemia. Normocytic means that MCV is gonna be around 80 to 100 femtoliters. That's the normal, let's say, size of the RBC, and 80 to 100 femtoliters. And if it's gonna be less than that, it's gonna be microcytic. And if it's gonna be more than that, it's gonna be macrocytic. So these are the values, which is more than 100 macrocytic, less than 80 microcytic. And coming to, let's start with microcytic. So microcytic anemia is usually happening because we have low hemoglobin production in that anemia. And if we have low hemoglobin production, that means in that RBC there's going to be low hemoglobin. That RBC will divide so that it can make it kind of equal. So that's what it says, extra division. So it will divide once more so that it could compensate and make the hemoglobin equal, and that's why we will have smaller RBCs, because it's going to do an extra division. And a mnemonic to remember microcytic anemia is SITA, which is S for sideroblastic anemia, I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. And normocytic anemia, the examples are post-hemorrhagic anemia, which we will discuss more in detail in the upcoming slides, hemolytic anemia, which consists of extravascular, which consists of sickle cells, ferrocytosis, intravascular, which consists of paroxysmal nocturnal hemoglobinuria, glucose 6-phosphate dehydrogenase deficiency, immune hemolytic anemia, and malaria, which again we're going to discuss more, decreased erythropoiesis, which is happening in aplastic anemia, and pancytopenia, which is disorders in the bone marrow. Macrocytic is also known as megaloblastic anemia, and we will see macrocytic in folate deficiency and vitamin B12 deficiency. Anemia based on color basically means that when the hemoglobin concentration, let's say it's less, which we determine by mean corpuscular hemoglobin concentration. And if it's less than 30 gram per deciliter, so hemoglobin gives the color. So it's just gonna be pale. The RBCs are gonna be pale. And we usually see it in microcytic anemias. That's why we're gonna say hyperchromic microcytic anemias, which is small pale RBCs. Normochromic means that it's completely normal. The RBCs, the color is completely normal because it's in under the range, which is 30 to 35 gram per deciliter. Now, this is really important, guys. This is the second classification, which is the etiological classification by cause. This flowchart, I have listed all the anemias that are there properly into their proper classifications. And if you guys draw this flowchart and the morphological classification flowchart, I think you're good to go for the exam. Explain about these, explain the different anemias from these. But first, show the examiner drawn a flowchart on the morphological classification and on the etiological classification. So this shows that you know all the different types of anemias that are there. Starting off with post-hemorrhagic anemia, so this happens because of blood loss. So that could be either acute or that could be either chronic. Now, acute bleeding, which is caused by trauma or GI bleeding, so severe blood loss can lead to shock. And if we follow hemodive, we know that shock is decreased perfusion, low blood pressure in the tissues. And so we do a fluid infusion, and that can lead to hemodilution. And the body starts compensating for this hemodilution by increasing red blood cell production, which is reticulocytosis. In chronic bleeding, it's long-term bleeding, which can happen because of ulcers, which is maybe in your GIT, and that can lead to iron deficiency anemia, which is typically hypochromic microcytic anemia, which is small pale RBCs that we just discussed. The next classification, which was hemolytic anemia. In hemolytic anemia, we're normally going to see normocytic anemia, and we can divide this into extravascular and intravascular. Extravascular means that the RBCs are going to be destroyed by extravascular in the reticuloendothelial system by the macrophages in the spleen, liver, and lymph nodes. And intravascular means that it's happening in the vessels. So that could be like within the RBC, intracorpuscular, or something that's attacking the RBC, which is extracorpuscular. So let's dive into more detail about these topics. Now, extravascular hemolysis is RBC destruction by macrophages in the spleen, the liver, and the lymph nodes. And normally we know that when RBCs are old, which is around 120 days, they're removed by the spleen. But then when we have like a pathological disease like sickle cell anemia or spherocytosis, the RBCs become defective and they're destroyed faster. Now we know the general hemoglobin breakdown from biochemistry that globin in the hemoglobin is broken down into amino acids, and the heme is broken down into iron, which is going to be recycled, and protoporphyrin, which is going to turn into unconjugated bilirubin. And this unconjugated bilirubin goes to the liver for excretion. Now the thing is, when these cells RBCs are destroyed faster in these processes, which is sickle cell or spherocytosis, so you can see some clinical findings. You can see anemia with splenomegaly because more RBCs are going to the spleen now, and then jaundice because of the unconjugated bilirubin, risk of bilirubin gallstones because of the unconjugated bilirubin, and reticulocytosis because the bone marrow starts to compensate for these missing destroyed RBCs and starts producing more, which is reticulocytosis. In extravascular hemolysis, we have sickle cell anemia and spherocytosis. Sickle cell anemia, I'm not going to go into the details. We know it's an autosomal recessive mutation in which glutamic acid is replaced by valine in beta chain, and the beta chain becomes defective, and we have sickling of the RBCs, especially in conditions when it's exposed to hypoxia, dehydration, and acidosis, and they polymerize, they become sickle cell shaped RBCs, and that's how the RBC is going to look. It's going to become defective. Now, the main thing I want to emphasize in sickle cell anemia are the complications. So, in complications, as we just discussed in the extravascular hemolysis, that we could have hemolysis and jaundice because of the unconjugated bilirubin, and that could lead to a risk of gallstones. In bone changes, on the X-ray, we would see on a skull X-ray crooked appearance, and bone changes are usually happening because of the hematopoiesis. Hematopoiesis extends into the skull, and in this picture, you can see the crooked skull on the X-ray, and you could see chipmunk faces in this picture that's seen in sickle cell anemia. And then we would see extramedullary hematopoiesis, like in the liver, for example. That's why we would have hepatomegaly, enlargement of the liver. Sickle cell anemia can also cause vascular occlusion because the sickle cells, they will block the blood vessels, especially to the spleen, and this can cause several complications like autosplenectomy, which is basically a shrunken, non-functional spleen. This can increase the infection by encapsulated organisms like strep pneumoniae, Haemophilus influenzae, Salmonella typhi, osteomyelitis. We can also see acute chest syndrome, which is pain in the chest, shortness of breath, and lung infiltrates due to vaso-occlusion, often triggered by pneumonia. This is the leading cause of death in adults. One more thing is that we would see Howell Jolly bodies, and these bodies are small, round nuclear remnants. We know that RBCs have no nucleus, but we see nuclear remnants of the red blood cell, and normally these nuclear remnants, they're removed by the spleen. But now we know that the spleen isn't functioning properly, and that's why we're going to see these bodies, Howell Jolly bodies, on the microscope. Next, we have is hereditary spherocytosis. In hereditary spherocytosis, what happens is that we have some proteins like ankyrin, spectrin, BAN3, and they become defective. And these are tethering proteins. They help to give the biconcave shape to the RBC. And now, since these proteins are defective, so the RBCs are going to lose their biconcave shape and they'll become like spheres. So that's why we call them spherocytes, because they have the shape of a sphere. So these spherocytes are destroyed by these splenic macrophages because the RBCs are defective now, and thus we get anemia. In the next slide, in this picture, we can have a good look on what exactly is happening. So these are the proteins. You have your ankyrin, you have your spectrin, and they become defective. So this starts to lose its biconcave shape, becomes like a sphere, and this spherocyte gets engulfed by the splenic macrophage and gets destroyed faster. So that was for extravascular hemolysis. We talked about sickle cell anemia and spherocytosis. And coming to intravascular hemolysis, intravascular hemolysis is RBC destruction that is happening inside the blood vessels. And if we have RBC destruction inside the blood vessels, as you can see over here, it's gonna cause hemoglobinemia, which is basically free hemoglobin in the blood. Hemoglobinuria, hemoglobin appears in the urine, which can increase the risk of acute tubular necrosis. Hemosideриnuria, which is these tubular cells are going to absorb the hemoglobin and then they will break it down into iron, and this is stored as hemosiderin, and these cells will be shed. These tubular cells are going to be shed. This will lead to hemosiderin in the urine. And then we have decreased serum haptoglobulin because the haptoglobulin will bind to hemoglobin to conserve it. Starting off with glucose 6 phosphate deficiency, we know that it is an X-linked recessive disorder that leads to reduced half-life of this enzyme, which is G6PD-H. And if you guys can see, I have drawn this simple scheme that we learned in biochemistry. In RBCs, we have glutathione, and we also have the pentose phosphate pathway in which this enzyme is going to be used. So we have G6P, which is glucose 6 phosphate, is going to get converted to 6 phosphogluconolactone, and this enzyme is going to be used, G6PDH. So what happens is that when it's going from this to this, you have the NADP plus is being utilized and being reduced to NADPH, and that is done by glutathione reductase. So there are two enzymes, glutathione peroxidase and glutathione reductase. And when we have free radicals, which is oxidative stress in the RBCs, and it's getting converted into H2O2 hydrogen peroxide, this glutathione peroxidase will reduce it and form H2O. Whereas on the other hand, this reduced glutathione now becomes oxidized glutathione, and we need to recycle it back to the reduced glutathione because we need glutathione to avoid oxidative stress in the RBC. So what we do is we take glutathione reductase, and glutathione reductase will utilize this NADPH to convert the oxidized glutathione back to reduced glutathione. And this is the cycle, and that's why this enzyme becomes necessary, because if there's no enzyme, there's no NADPH, and if there's no NADPH, it becomes hard for the oxidized glutathione to come back to the reduced glutathione. And that is why this is really important, and that's why like infections, drugs, anti-malarial, sulfur drugs, fava beans, everything that is causing oxidative stress in our body is gonna trigger this. And when we see under blood smear, we can see Heinz bodies, and Heinz bodies is basically denatured hemoglobin because of the oxidative stress. And what happens is that the macrophages, they will try to remove these Heinz bodies, which will result in a bitten erythrocyte. It looks like someone like bit it, which is the macrophages in this case. after G6-PTH deficiency is paroxysmal nocturnal hemoglobinuria. And what happens over here is that it is an acquired defect in myeloid stem cells. There is an absence of GPI, which is glucosyl phosphatidylinositol. It's an anchor which anchors DAF. DAF is decay accelerating factor, and this DAF is what prevents the complement's activation. So let's say if this GPI is not there, so there's nothing to anchor the DAF, so there's no DAF eventually, and then this complement system can easily attack all the myeloid stem cells. Now, why are we saying that it's paroxysmal and nocturnal? It's because intravascular hemolysis, it's gonna occur episodically, which is often at night. That's why nocturnal. And this is due to respiratory acidosis, which is from shallow breathing during sleep. This can activate the complement system. Now, because it's affecting all the myeloid stem cells, RBCs, white blood cells, platelets, everything is lysed, and this can lead to hemoglobinuria, hemoglobinuria, and hemosideриnuria. The complications is everything gets lysed, which is platelets, granulocytes, RBCs, and their relative deficiencies will lead to, like for platelets, bleeding, granulocytes deficiency will lead to infection in RBCs, deficiency will lead to anemia, and this can also progress to acute myeloid leukemia, which is a type of cancer that we will discuss in the further videos. So now we're done talking about the intracorpuscular hemolytic anemia, and now we're going to talk about the extracorpuscular hemolytic anemia, that is normal RBCs that are being attacked by autoantibodies, infections like malaria, or mechanical damage. In autoimmune hemolytic anemia, it could be IgG mediated or IgM mediated. IgG is causing extravascular hemolysis, whereas IgM is intravascular hemolysis. Now, the reason why we're saying IgG is warm, it's because IgG will bind to RBCs in a warmer central body temperatures, and this will lead to partial phagocytosis by the splenic macrophages, which will lead to the formation of spherocytes. And the causes can be in systemic lupus erythematosus, in chronic lymphocytic leukemia, or in drugs. This is where it's going to happen, like drugs such as penicillin. And in IgM mediated, the reason why we're saying it's cold, it's because IgM binds to RBCs in colder extremities, triggering complement activation and RBC destruction via the MAC complex. And this can happen in Mycoplasma pneumonia, Epstein-Barr virus, cytomegalovirus. Symptom is Raynaud's phenomena, and Raynaud's phenomena basically means that it's cold-induced vasospasm, which is going to cause pallor, cyanosis, ischemia, and hypoxia, especially in the extremities like fingers and toes. Next is microangiopathic hemolytic anemia, and this intravascular hemolysis is going to happen because of vascular damage. So we know vessels can be damaged due to like microthrombi formation, like in thrombotic thrombocytopenic purpura, or there's presence of prosthetic walls and aortic stenosis. So whenever RBCs are going to pass through this damage, so the RBCs are going to get mechanically damaged, and this will lead to the formation of schistocytes that can be seen on blood smear. Next, we're going to talk about malaria, and as we know, it's an infection with Plasmodium, which is transmitted by the female Anopheles mosquito, and that affects the RBCs and the liver. So we see intravascular hemolysis in malaria, and it occurs as the RBCs rupture during the Plasmodium's life cycle, and this is causing a cyclical fever. So in species such as Plasmodium falciparum, we would see daily fever, whereas in Plasmodium vivax or ovale, fever would be every other day. The spleen itself also destroys some infected RBCs. So this can lead to mild extravascular hemolysis and splenomegaly. But it's malaria is mainly intravascular hemolysis, but it can lead to extravascular hemolysis. So we're done with the hemolytic anemia, which was the second part of the classification. Now we move on to the third part of the classification, which is defective or decreased erythropoiesis. There's some problem in the synthesis of the hemoglobin or the RBCs itself. So there are five classifications under this, which is it could be disorders of DNA synthesis, disorders with heme synthesis, disorders with defective, there's no proper globin chain being produced, disorders with the bone marrow, or disorders with erythropoietin. Starting off with disorders of DNA synthesis. In DNA synthesis, we have folate deficiency and vitamin B12 deficiency. Now, it is similar, however, there are some differences between the two. So, let's start with folate deficiency. Folate deficiency, the causes could be poor diet, like less green, intake of green vegetables, increased demand, like in pregnancy, cancer, hemolytic anemia, or it could be folate antagonists like methotrexate, which we have studied in biochemistry. Main is clinical signs of folate deficiency is glossitis, which is inflammation of the tongue. We can see it on the patient's tongue. We could see macrocytic RBCs, which is enlarged big RBCs, and we can see hypersegmented neutrophils. The neutrophils would be hypersegmented as as we can see in the picture. In the lab, when we do tests, we would find that the serum folate has been decreased and homocysteine has been increased, which can lead to a risk of thrombosis. Now, one thing to rule out that it's not B12 deficiency is that the methylmalonic acid, which is more biochem related, but that's going to be normal. And that's all about folate deficiency that's necessary to know. Next is vitamin B12 deficiency, and let me start off with the digestion process on how this vitamin B12 is absorbed in our body. So we know we have salivary enzymes like amylase, for example, and this will release the B12 from our food, which will bind to our binder over here. After that, it goes into the stomach, and we have pancreatic enzymes in the duodenum that will detach the B12 from the R binder. This B12 will then bind to intrinsic factor that is released by parietal cells in the stomach, and this intrinsic factor B12 complex is absorbed in the ileum. Transcobalamin will deliver this B12 for storage into the liver. Now, the causes of B12 deficiency is pernicious anemia, which is the most common, like it's the autoimmune destruction of the parietal cells that leads to intrinsic factor deficiency. So, vitamin B12 does not get absorbed. Then, pancreatic insufficiency, damage to the terminal ileum, like example in Crohn's disease or fish tapeworm, or dietary deficiency, which is really rare except in vegans. Clinical signs are going to be similar to folate deficiency, which is macrocytic RBCs and hypersegmented neutrophils. We would see glossitis as well on the patient. And in this vitamin B12 deficiency, we're going to see subacute combined degeneration of the spinal cord, which will lead to poor proprioception, vibratory sense, and spastic paralysis. And this is because we have, in folate deficiency, we had normal levels of methylmalonic acid. However, we have increased levels of methylmalonic acid in vitamin B12 deficiency, and this impairs the spinal cord myelinization, and that's why we see these symptoms. That's on disorders with DNA synthesis. Moving on to disorders with heme synthesis, this is the mnemonic that we studied before, Sita, but not the T over here. Everything except the T, which is sideroblastic anemia, iron deficiency anemia, and anemia of chronic disease. And because it's disorder with the heme synthesis, we would see microcytic anemia. All of them are going to be microcytic anemia. Starting off with iron deficiency anemia, this is the number one cause of anemia, and it's also called sideropenic anemia. And what happens in this is that when low iron is absorbed in our body, so we're gonna have low heme production, and low heme production is gonna lead to low hemoglobin, and that will eventually lead to microcytic hypochromic anemia. Now let's get thorough on how iron is exactly being absorbed in our body. Iron is absorbed in the duodenum from meat and vegetables, and it goes into the enterocytes through the transporter DMT1. From DMT1 through this transporter, this one, which is called ferroportin, it is going to be transported into the blood, and transferrin is going to bind to it. Transferrin binds to this and takes it to storage sites such as bone marrow and the liver. They're stored over there as hemosiderin or ferritin to prevent harmful free radicals that can form through Fenton reaction. So let's say if the storage of iron is full. So hepcidin is going to be produced, and this hepcidin will go and act on ferroportin and will inhibit this transporter. So now no matter how much iron is absorbed, it does not get transported in the blood because this is blocked. This area is blocked. Ferroportin is blocked because of hepcidin. And this concept, we're going to discuss it in the next further upcoming anemia. So let's continue. For iron deficiency anemia, the causes are dietary deficiency, like in infants, poor diet, chronic bleeding, like you could have ulcers, peptic ulcers, colon cancer, heavy menstruation, or increased demand, like in pregnancy or cancer, or malabsorption, like in celiac disease. In clinical features, as we already discussed, we can see microcytic hypochromic anemia. We can see pica, which is craving like non-food substances like dirt or hair. And then we could see spoon-shaped nails like koilonychia, as we can see in the picture. So the next one, which is anemia of chronic disease, in this anemia is linked to chronic conditions like endocarditis, autoimmune diseases, and cancer. And what happens is that when we have chronic diseases, it triggers the production of an acute phase protein, which is called hepcidin. And hepcidin, as we just discussed in the previous slide, blocks ferroportin. So it degrades the ferroportin in liver macrophages, and no more iron can be transported to the storage site. And also, this reduces the erythropoietin production in the kidneys. Why this happens is because bacteria needs iron to survive, and to avoid giving bacteria iron, our body has this mechanism to stop accessing the iron which is needed for their survival. In lab findings, we can see increased ferritin, that is the storage form of iron. We would see decreased transferrin, which is the transport form of iron, and decreased serum iron and low percentage saturation. Next is sideroblastic anemia. Sideroblastic anemia results from defective protoporphyrin synthesis. And we know protoporphyrin is needed in heme. So if we have less protoporphyrin, less heme is going to be produced, which will eventually result in less hemoglobin production and which forms microcytic hypochromic anemia. Without enough protoporphyrin, iron will get trapped in the mitochondria of erythroid precursors, forming ringed sideroblasts. And are iron-filled mitochondria around the nucleus. The causes could be congenital or acquired. In congenital, we have deficiency of the ALase enzyme that we know in the heme synthesis, which is basically the protoporphyrin synthesis, the first step. And in acquired, it could be alcoholism, lead poisoning, as we know from biochemistry, it's inhibiting ALAD and ferrochelatase, the end process of heme formation, and vitamin B6 deficiency, which is needed for ALS, common in isoniazid treatment. We can see vitamin B6 deficiency in isoniazid treatment. Coming to the next part, which is disorders with defective globin chain. In disorders with defective globin chain, it's only thalassemia, which is divided into alpha thalassemia and beta thalassemia. And since it's with the globin chain, so low globin chain, so obviously microcytic anemia. So there are two types of thalassemia, which is alpha thalassemia. In this, its reduction in the alpha globin production depends on the number of genes affected. So it could range from mild anemia to severe cases like HBH disease or fatal hydros fetalis. And over here you can see target cells. That's because less hemoglobin is being produced. So that's why target cells are seen in alpha thalassemia. Next is beta thalassemia. As we discussed in sickle cell anemia about the chipmunk faces and the crooked skull appearance in the x-ray, same we see it in beta thalassemia. And there are two types of beta thalassemia, minor and major. Minor is usually mild anemia and major is severe anemia, and we have absent or reduced beta globin production. Disorders with bone marrow, we have two types, which is aplastic anemia and myelophthisic anemia. Aplastic anemia, which is pancytopenia due to bone marrow insufficiency, all the cells are affected, so you have decreased RBCs, decreased platelets, decreased white blood cells, which causes anemia, thrombocytopenia, and leukopenia respectively. And inborn, we have Fanconi anemia, which is inherited mutation affecting DNA repair, and if obviously DNA doesn't repair, then we'll have cell death. Acquired could be damage to the hematopoietic stem cells, like by drugs, chemicals, viral infections, or autoimmune causes. Then we know about the virus, parvovirus B19, which infects progenitor red cells and it halts only erythropoiesis. This can cause anemia as well, especially in conditions with existing marrow stress, like sickle cell anemia. Next is myelophthisic anemia. In this, the bone marrow is going to be replaced by something else like fibrotic tissue or adipose tissue or maybe a tumor. So the outcome is obviously hematopoiesis will be impaired, and again we would have pancytopenia with all the cells would be decreased. Compensation would be like extramedullary hematopoiesis in the spleen and in the liver, and that leads to hepatosplenomegaly. Causes are tumors, tuberculosis, lipid storage diseases like fat accumulation, or it could be myelofibrosis, which could be primary, which is idiopathic, or secondary, which is related to neoplasms or metastasis. Lastly, we have disorders with EPO, which is erythropoietin, and this happens in anemia of chronic kidney disease. We know that the kidney produces erythropoietin when we have low RBCs in the body, and when we have chronic kidney disease, no production of erythropoietin, and this decreases hematopoiesis, and we can get anemia. We are done discussing all the types of anemia, and I brought this flowchart again. So we discussed in post-hemorrhagic anemia, there was acute bleeding, chronic bleeding. In hemolytic anemia, divided into extravascular and intravascular. Extravascular had sickle cell anemia and hereditary spherocytosis. Intravascular was divided into intracorpuscular and extracorpuscular, which consists Intracorpuscular consisted of G6-PDH deficiency and paroxysmal nocturnal hemoglobinuria, and extracorpuscular consisted of autoimmune hemolytic anemia, which could be IgG or IgM mediated, microangiopathic hemolytic anemia, or infection such as with malaria. Then the third classification that we discussed was defective or decreased erythropoiesis, which is disorders of DNA synthesis, disorders with heme synthesis, disorders with defective globin chain, disorders with bone marrow, and disorders with EPO. And yes, that's it.